Today's focus is on the health disparities in COVID-19 in Maine. The Greater Portland Council of Governments launched this series after multiple city and town managers asked us to help them take action to advance racial equity. Federal, state, regional, and local government has played and continues to play an important role in shaping our economy and our society. Our investments in policies, explicitly in the past and implicitly now, disadvantage Black, Indigenous, and people of color. And in our first webinar, we took a dive into this. We learned that we inherited systems in which discrimination is baked into our society, our economy, and our educational institutions. It's easy to think of racism as a personal animosity, that it raises feelings of guilt and shame. And while this type of personal racism exists in the world and is horrible, and it makes the conversations that we're trying to have uncomfortable and difficult, it's only part of the problem. This year, 2020, comes after slavery in this country and after Jim Crow laws, which mandated segregation between the era of Reconstruction and the 1964 Civil Rights Act. It comes after redlining denied mortgages to inner city residents, and after transportation decisions were made to put highways through those same inner city residents that were neighborhoods of immigrants and people of color. It also comes after the GI Bill didn't confer the benefits on Black veterans in the same way it did on white veterans. We sit on top of years of history that have affected the opportunities and advantages of white people and Black people. White people have had advantages and opportunities, and Black people have been denied some of the same ones. This series of webinars dives into today's different types of inequities. Today, we're focusing on public health and COVID-19, but it's important to realize that this is a disparity that is a symptom of underlying institutional and structural racism. And we, all of us in local government, and I can tell there's a lot of folks interested in this by the number of webinar attendees, we in local government can take action to address this kind of structural racism. We have policies that affect our local schools and the funding levels, how we plan and zone for housing, how we plan and offer transportation to people, and then our practices in policing and in hiring. This morning, the Associated Press reported that worldwide we have 20 million COVID cases and 25% of those are in the US. The good news in Maine, as we all know, is that we have one of the lowest positivity test rates in the country. But the bad news is that we have the worst racial disparity in the nation for COVID-19. Black people in Maine make up 1.4% of our population, but they comprise 22% of our COVID cases. It's astounding. The Latinx population is only 1% in Maine, but comprise 4% of the cases. And for Asians, 1% again of the population, 3% of the cases. And nationally, Black people are 2.5 times as likely to die from COVID-19 as white people. Last week, the CDC reported nationally that there are 600 kids that were hospitalized with COVID-19. 1 in 5 of those were infants under 3 months old, and 1 in 3 ended up in the ICU. But Black kids are 5 times as likely as whites to be hospitalized for COVID-19. And Latinx kids, the rate is even higher at 8 times. Health disparities for Black, Indigenous, and people of color are nothing new. You can look at just about any health indicator, whether it's infant mortality or chronic disease, and across the board, you'll see racial disparities. But today's COVID crisis puts into clear focus these underlying health disparities and makes us as a society refocus on them. Excuse me. Our panelists today have been on the front lines of this crisis in Maine. They've been dealing with really difficult circumstances, ones I can hardly imagine. Emotions, sadness, and I also expect that they're very weary of this issue. I'm really grateful to them for carving out not only the time, but also making the energy to help us understand what they're experiencing and go deeper into some of these health disparities in Maine. We're also joined by Department of Health and Human Services officials and state government. They're making policies and tailoring them to try to address some of these racial disparities. They understand that no size fits all, no one size. It's important for all of us who are making decisions to engage people of color in listening and understanding the unique circumstances. The people of color have been advising the Mills administration on disparities. And on July 30th, $1 million of the Coronavirus Relief Fund has been dedicated to reducing racial and ethnic disparities in COVID-19. To go and take a deep dive into this, we're going to be introducing our panelists. And to introduce our panelists, we have Tori Pelletier. She's GPCOG's project manager for racial equity. And for those of you who joined us in our first webinar, you'll know that she had the generosity and the courage to share her story about what it was like to grow up as a Black girl in Brunswick and make her way as a Black woman in Maine. She's helping those of us who are white to better understand what it's like to walk in the shoes of a Black person in Maine. If you didn't get a chance to see her story in the last webinar, I urge you to take a little dive on our website to our racial equity page and see her story on video. It's truly moving. Tori, I'm going to ask you to take it from here. Thanks.
Thank you, Christina, very much. I appreciate it. And thank you everyone again for being here for our second webinar installment, Racial and Ethnic Disparities and COVID-19. We have an amazing panel for you this afternoon, and we're looking forward to hearing their stories, as Christina said, hearing their knowledge, and we're really appreciative of them taking the time to share their expertise with us. So before we dive in, I do want to make a note about questions, as I know they will come up. We will again be doing a question and answer portion at the end with all of our panelists. And during this webinar, we do have 3 ways for you to ask your questions. So the first is by submitting them through the Q&A portal, which all of you should have at the bottom of your screen. The second is by sending an email. You can send it to me at vpelletier@gpcog.org. You can also send it to info@gpcog.org, and we'll make sure that that question gets answered. And the third way is to send a brief question as a text message, and you can send that message to 207-751-0252. All of this information is also in the Zoom webinar chat, so you should be able to read that and send your questions in as you like. We have 2 awesome moderators behind the scenes. Shout out to Ping and Tom, and we will be doing our best to get to as many questions as we can. However, there are about 145 of you here at this time. So unfortunately, we're not going to be able to get to everything. But that being said, we will make a point to follow up after the webinar. So if you have something that didn't get answered or you have a follow-up question, please feel free to email us and we'll make sure that we either answer it ourselves or send it to the applicable panelist. So I don't want to take up any more time on screen. So without further ado, I'm going to introduce our first panelist, Crystal Cron, who many of you may know. Crystal is the president of Presente, Maine, an organization that works to support and empower the immigrant communities, particularly the Latinx community, through education, community organizing, and civic engagement. When the pandemic hit Maine, Crystal actually created the Food Brigade, delivering food to some of our region's most vulnerable areas. It's a pleasure to have Crystal on panel, and I'm really looking forward to hearing more of her story. And here she is on screen, so Crystal, go ahead and take it away.
Thank you so much. I'm so happy to be here. So I was going to share a personal story about myself to really paint a picture of what it's like to be me, a poor brown person in Maine. But I realized that I'm getting tired of storytelling and that I don't need people to feel sad for me, and my community doesn't just need compassion, but we need funding. We need real investment and not just as an afterthought in a global pandemic. Since before the first case of COVID-19 hit Maine, I've been predicting and dreading the impact on the Latinx community. I knew that essential workers would be hit the hardest. I knew that essential workers and poor people, especially Black and brown people, would be blamed for spikes in cases. I knew that people would have no choice but to continue to work because of the lack of social supports available, either because of being undocumented or because of inefficiencies in the system. And I knew that a huge factor in the spread of disease would be inability to social distance because of the work environments and living conditions that make it impossible. And just to give you a little more information about that, my community, and I've been saying this since the beginning, lives in 3 or 4 bedroom apartments, usually 1 family in each apartment. And so an apartment can have anywhere from 15 to 20 people. And when we talk about quarantine or we talk about isolation, where do people go if they share a room with 5 other people in an apartment with 20 other people? So on March 15th, I recorded a video and I began sending it to everyone in my community, urging them to stay home, explaining the risks, explaining precautions, and I made a commitment to them that I would do everything in my power to support them. But my community is smart and they remember history and they knew that nobody was coming. And so I got message after message saying, "Thank you, Crystal, but if I don't work, I don't eat, and I'll have no way to support my family. I'll be on the street." The next day, we started buying bulk rice and beans and delivering it straight to people's doors. We started with 50 people, the next day 200 people, and now we're feeding 2,000 people weekly. These are families who don't have access to SNAP, GA, TANF, Maine Care, unemployment, or the federal stimulus. And it makes me really happy to do this work. I don't see myself as somebody who works in the community. I am of the community. They are me and I am them. But rice and beans are not enough, and it's a community solution to a government problem. I need real investment in my community. Latinx are not new to our state. We've been around for a long time. We're the largest minority in Maine with more than 25,000 people. We pick your blueberries, we harvest your broccoli and potatoes, we build your houses, we clean your toilets, we fluff your pillows, we wash your dishes. We pick and pack your lobster, an industry that brings nearly $1 million into the Maine economy every year. And yet my community must endure 16-hour days at a pay rate of 40 cents a pound for lobster meat that's sold at market for $60 a pound, even through a global pandemic, and they barely scrape by. So I'm getting really tired of storytelling, because I share these stories that for me mean everything, that for me aren't just stories. These are people, these are the real life experiences of people that I'm in community with. And I see over and over again that it goes unheard. We're in a crisis. Outbreaks in my community continue to rise, and people are afraid to get tested and seek treatment because eviction and joblessness are more lethal than COVID. So we need to take this opportunity that the crisis has presented us and rethink the current structures. We've reopened the economy at the expense of these families, and we continue to give tax breaks to the rich and to corporations. The 2019 tax expenditure report shows that 3 tax credits were enacted since the prior year. The credit for major business headquarters expansion, the employer credit for family leave, and the shipbuilding credit. Companies don't need more tax breaks to move here. We know that Maine is desirable and we have an eager workforce, and subsidizing the establishment of headquarters probably doesn't even translate to jobs for us, the poor and vulnerable. We need universal leave. Why are we giving tax breaks to companies when we all deserve leave, and the government could provide it to us directly, especially during a time like this in a pandemic? And then Bath Iron Works and General Dynamics workers are currently on strike because the company wants to contract out all jobs, and yet we, and especially the undocumented workers who receive nothing back from the taxes that they pay, are subsidizing a shipbuilding tax credit. Even if we look at just one item from that report, products used in agricultural and aquaculture production and bait, these funds can make a huge impact on our community. Over $7 million are being taken from the general fund to subsidize hormones, pesticides, fertilizers, and antibiotics that are used in agriculture, aquaculture, and commercial fishing. That, if you remember from the comment I made about lobster, it's bringing in nearly $1 billion, and my Latinx siblings make 40 cents a pound. So how can we subsidize $7 million for companies but not people? And let's not also forget that blueberries are the #1 export in Maine. So basically, we're subsidizing the poisons that are used in all the industries where my families work. These tax credits mean less money for people and less money for health. And not collecting this money means not investing in our communities. Let's value the lives and the basic needs, food, shelter, and health of our communities before companies. Then we can stop asking why racial disparities exist, since we know that race is a construct and that the disparities are a result of conditions that are created to oppress and leave us behind. Thank you.
Again, for those powerful words and just for being a really fantastic and inspiring individual. I'm really appreciative of your time. So thank you again for being here with us today. And going right into our next panelist, just in the interest of time, we do have Dr. Beth Wilson. Dr. Wilson is a family physician at Maine Medical Partners Family Medicine Center in Portland. Beth's work and research focuses on healthcare disparities, workforce diversity, and medical education. And Beth, we are happy to have you kick us off on the big picture of COVID-19 and racial disparities. I see that you are here, so feel free to take it away.
Great. Thank you so much for including me today. This is a really important topic, and I think Crystal sort of gave us everything we need to think about. And so my job is to sort of, I guess, go to the bird's eye view for a moment and just kind of review some of the basics around disparities. So you've already covered structural racism. We've talked about communities and policies, and I'm just going to put it into kind of a little bit of an academic concept and construct to show a little bit of the history around disparities. And I'm going to ask Tom to share my slides. There we go. Terrific. Thank you. So, you know, in some ways, when we have these conversations, I think it's really important that we have a shared language around these conversations before we start making assumptions of about what kind of everyone understands. So these are some super basic definitions, although I think sometimes we forget. I'm in healthcare. Sometimes we think of health as the absence of disease, and it's not. It's a much more comprehensive state than that, with physical, mental, and social well-being. Health equity is really attaining the highest level of health for everybody. When we talk about disparities, we're really talking health disparities are differences and a higher burden of illness, injury, disability, or mortality in one group compared to another. And that difference is not, is unfair. Healthcare disparity is what happens in the healthcare system, and it can be due to health insurance coverage, access to healthcare, how people are able to use healthcare, and the quality of healthcare. Next slide, please. So what determines health? So all three people so far in the beginning of this webinar discussed this, and I'm just going to put it again a little bit into context. So when we think about what determines health, or why people are at risk for premature death, we often divide it into these categories. I'm not going to talk about genetics, but I am going to talk about the rest of these groupings because they're all very much relevant to what we're here to talk about today. Next slide. So in social determinants, so Crystal actually spoke she talked about housing, she talked about employment, she talked about all the factors that impact her community. And these are what really determine health. You hear about people saying place matters. It absolutely matters. It matters, but it's not just place, it's education. It's what happens when you leave your housing. Is there a safe park to walk around in? Can you get a job? Do you have to work multiple jobs? Can you get insurance? Do you have support systems? And all of those things sit outside of the healthcare system. So it's absolutely true that we need to work on healthcare solutions, but it's also to change health disparities, we actually have to address all of these factors. Next slide. So a lot of people talk about health behaviors and they say, oh, well, that person is making poor choices. I have concerns about those conclusions, because really people don't make choices in a vacuum. They make choices based on relationships, family, culture, values, about the organizations that they live, play, and work in, the communities where they live, as well as policies. These are what drive choices, not just whether an individual feels like doing something or not. Next slide. So, and I don't want to leave out the healthcare piece. This is sort of my world, and this is the image on the left is from a 2002 report called Unequal Treatment, and Congress actually charged the Institute of Medicine to look into disparities, and one of the things they asked was, is there a contribution from providers and from our healthcare system? And the conclusion was very clear that yes, provider bias and the way our systems are built, which we know, but they were really able to show this looking at hundreds and hundreds of articles and compiling the evidence. And this really shifted the way we thought about disparities in healthcare. And as we know, we have closed some gaps, but other gaps have widened. And that's why we're here today to talk about this. We have not found the solution. Next slide. So this is just you could do multiple slides, probably hundreds of slides, just showing reports, articles that detail disparities over the decades. So that's unequal treatment is on the left, and that's the one I mentioned before. The CDC puts out regular reports. The Agency for Healthcare Research and Quality also puts out regular reports. And then there's studies that look at things and look at, okay, if we have provider bias and we know that, what are some interventions we can do to reduce that? So there is not a lack of research. And so one of the things I often tell people that I work with, especially our students and our trainees, is this is just like any evidence about any health issue, is you look at the evidence and you make your argument based on the evidence. And then you broaden your scope so that you're really thinking about what we're talking about here today, and how it's not just healthcare, it's a much broader landscape in terms of what determines our health. Next slide. So I'm going to let our next speaker delve into this more, but this is just a snapshot at the national level of the disparities in COVID deaths. I think all you have to do is look at this briefly and you get the sense that something is wrong. So we talked earlier about the sort of percentage of Blacks in Maine versus the percent who actually have COVID. This is a huge disparity, and it's brought us to this point of saying, disparities existed. We're very clear about that. But now we're saying, here it is highlighted, and it's time for us to do something. And I think I agree with Crystal. I mean, the narratives and the stories are important. I think that helps tell a story. But what we need is action, we need resources, and we need a really coordinated effort to think about how do we address these disparities. Next slide. So this is my final slide, just to, again, set the stage. So this is a complex problem, and obviously it requires complex solutions. I like the idea of like rice and beans not being enough, right? It's so important, and yet it's not enough. Housing, so important, but not enough. It's the people we work with, whether or not those people are represented in decision-making processes. It's the systems and the processes that we design. It's our structures. It's how healthcare is delivered, and it's also our policy and our laws. So I'm going to leave it at that and hand it off to our next speaker.
But I did just want to talk a little bit about Lisa. She's a senior advisor at Maine DHHS. She's an experienced physician leader and a passionate advocate for healthcare system delivery change, with particular interest in advancing primary care, behavioral health integration, and rural health.
This is Lisa Letourneau. Thanks, Beth and Crystal and everyone for teeing us up. I am an internist by background and work as the senior advisor within the Department of Health and Human Services within the state of Maine, helping to advise on issues related to clinical care and connections with clinicians. So in follow-up of Beth's great job teeing up some of the issues here, I was going to delve more into issues related to the data specifically in Maine. And I was going to run through a couple of slides here that illustrate that. So we'll jump in. We know this is an issue. We know it's an issue in Maine and nationally. And even before we saw this very unfortunate and unhappy headline here, noting that Maine has the worst rate of racial disparity meaning the disparity between the size of the population of people of color, in this case, Black population, and COVID prevalence. We were looking at this at Maine DHHS. I'm very pleased that I will be followed by my colleague Leana Amaez from Maine DHHS to talk more about what the state is doing about this. But as Beth said, certainly something that we are very aware of and committed to working on, and we know it's going to be a long and complicated set of solutions. But I was asked to focus on what the data looks like in Maine. I wanted to share that this data is available. The Maine CDC has made a commitment through its data resources and the state CDC webpage that reports on COVID data to add race and ethnicity data and tracking on that data in its website. So you can see a screenshot here, you see the link here, and then just a little bit of background. There are tabs across the top if people are trying to navigate this, and there are different tabs for race and ethnicity. You can see here, I'm highlighting the one by race. You can toggle back and forth here, and it shows both the share of the population and share of cases, deaths, hospitalizations, etc. The data is updated daily on overall cases, but the other data weekly, because the cell sizes are relatively small in some cases, and we want to be sure to protect privacy. Just to dig into some of that data a bit, again, we know from this data, in comparison to other states, that we have the biggest gap among Black Mainers, representing, and I think Crystal or somebody said earlier, right, only 1.4% of the Maine population, but a much higher rate of disease prevalence, representing 22% of COVID cases in cases where race is known, 10% of hospitalization, and 3.3% of deaths. Additionally, among Asians, only 1.2% of the population, but 2.6% of cases and 3.1% of hospitalizations. Similarly, in the Hispanic or Latinx population, 1.7% of the population, but 4.2% of cases. There we're not seeing similar disparities in deaths or hospitalizations, but clearly with increased prevalence, certainly people are at risk of that. Here, I just wanted to show you some of the background data, and I believe we'll make these slides available, just highlighting some of these areas, showing the disparities by race and, again, ethnicity. Too much clearly to go into every line of detail today, but this is just the background data, and again, we're happy to make that available to attendees. And then I think, you know, digging into this, why are we seeing those gaps? I think to echo, again, the earlier speakers, we know that these gaps are very likely a manifestation of longstanding structural racism and discrimination in this country, including chronic disparities in financial attainment and income gaps, housing, education, criminal justice system we haven't talked about yet, as well as access to healthcare services and an understandable mistrust of the healthcare, the medical system. Again, each one of these things could be its own webinar, so I don't intend to either you know, go too quickly, but just to recognize that the disparities we're seeing in Maine are very likely due to this, and those are both at the national level and in Maine as well. It's the same issues, very likely. Certainly, we've not had time yet to do the research to really be able to understand the differences between Maine and other states, but I think it is highly likely that those same issues of systemic racism are factoring in and unfortunately manifesting themselves in the data that we're seeing. And I think we all know that Maine, sadly, is not immune to racism. we have our own history to confront. I was fortunate to be able to hear the presentations in the first round of this webinar that JP Cog put on the last few weeks. And some of these are references to parts of our history that I think none of us are eager to look at, but we need to recognize. The first is a picture of the Ku Klux Klan marching in Portland, Maine, picture of our very dark history from Malaga Island and the segregation and deprivation that went on there. We know up and right through today, there's a photo of defamation of a mosque right in our state, and then we know. And Tori, I was able to hear your powerful testimonial about the micro and macro aggressions that go on with our communities of color today, again, in our state. So, you know, as somebody who's worked in healthcare quality in Maine for years, I have to say I certainly own my own part of this, working on quality, but not delving in. I think many of us sort of hid behind this, well, there's not many minorities in the state, but, you know, when we look at our overall data going back, the total non-white population in Maine, 5.7%, you know, nearly 6%. That's not a small number of 1.3 million people. And I think we all really need to think about how do we do a better job on multiple aspects of looking at systemic racism and bias in our state, and how do we do that? Additionally, I just wanted to offer a few thoughts coming from my perspective as a clinician in my role at DHHS, working with clinicians. And I know this audience is primarily not clinicians, but I think as municipal employees and elected officials, certainly working with the healthcare system is an important part of your role. And I think we are going to try to do more to work with clinicians to try to provide education and support, and some initial thoughts about, well, you know, what do we do? Certainly we need to work on these big systemic issues, but what do we do right now? And I think wanted to share just a few thoughts for clinicians and for communities. First one being for clinicians, get out into the community and listen. You know, I think it wouldn't be unusual to hear from some of my colleagues, well, we're not seeing these people, you know, what are we supposed to do? And I would say at 5.7% of the population, if you're not seeing them and serving them, then why not? What is happening in terms of your outreach, your connection with the community? Are there any opportunities to work with community health workers or community health outreach workers who come from the community, know better how to connect with and provide education? I think we all need to be aware of our own implicit biases in delivering care. Right now, I think one of the key messages that we are very much trying to promote as the state is to take action to promote testing, COVID testing for racially and ethnically diverse individuals, knowing that many of them are at higher risk, working in frontline jobs where they're interacting with the public and potentially experiencing more risk on a daily basis. We're also working, and Leana will go into this more, to talk about what we're doing to try to provide culturally and language appropriate specifics on the messages of quarantine, isolation, and state efforts at contact tracing. But again, as providers, I think we need to get much more familiar with this information and how to provide it in a way that is understandable and usable by diverse populations, and letting people know when they're tested that social services are available to support their isolation efforts. I think for communities and people in communities, we need to promote the basics of masking, social distancing, hand washing, staying home when sick, recognizing that those things, many of those things are not easy for many people from diverse populations, but we need to get that messaging out in a consistent way. Again, need to promote the messaging about testing. DHHS also made an effort to create what we're calling a standing order, meaning a physician's order that's available for anyone at risk for COVID, having been in contact with people or at risk for developing COVID. We've also been working to set up a series of what we're calling swab and send sites, and I'll show more on that in just a minute. Places where people can go using that standing order, where the test will be done at no charge to the individual and sent to the state lab for rapid turnaround and testing. And again, I think trying to promote this information in communities about culturally and linguistically appropriate specifics, not just saying you're being tested and you need to go into quarantine, but finding ways to support them. I did want to share the link to the governor's website, the Keep Maine Healthy website, with COVID information that includes a listing by county and town on where testing is available, and most importantly, that last column showing which facilities offer the swab and send services. Again, no cost to individuals with rapid turnaround of results. There are too many no's in there. We're working to add more yeses. This is just a screenshot. There are at least one site in most counties now, not everyone, but we are actively working to improve that. And then just wanted to list a few additional resources, including the COVID tracking project, which is the source of the racial data dashboard comparing Maine to other states. One of the best videos that I've seen from David Williams from the Harvard School of Public Health on understanding social inequities, particularly for clinicians, and then some resources from the US CDC. Included my contact information, and again, very much appreciate the work that GPCOG is doing to support these efforts. And with that, I will turn it back to Tori and then to my colleague, Leana Amaez.
Moving right along, we now have Leana Amaez, who is the Manager of Diversity, Equity, and Inclusion at the Maine Department of Health and Human Services. And Leana is going to talk more about her viewpoint on the racial disparities in COVID-19 cases in Maine. And she is here up on the screen, so I will let her take it away.
The disparities that were just described to all of you by Crystal Cron, Dr. Wilson, and Dr. Letourneau are obviously alarming and unacceptable. But what we know is that COVID did not create these disparities. It laid bare inequities that already existed, leaving some communities more vulnerable to infectious disease than others. We agree that those effects have been wildly disproportionate in the state, and that we have work to do as a state. We have work to do to address the systemic barriers, and at the same time, meet the immediate needs of providing support to those at risk and those already infected with COVID-19. I was asked to share today some of what the state has done over the past few months and is looking to do in response to COVID-19 and racial and ethnic disparities. And I began by creating a laundry list of efforts that we have made, and yet listening to my colleagues this morning, earlier in this webinar, and certainly hearing Crystal Cron open the webinar, I'm going to change my approach a little bit. And instead, I want to begin with a recognition that we have work yet to do, and that while the department has certainly been working collaboratively with the CDC, with Maine Care, with the Office of Aging and Disability Services, et cetera, to address the issues of COVID-19 and the racial disparities that we've seen, there's still so much more to do, and there is lots that we can learn from our approach. The department is committed to working with community-based organizations and community leaders to address these issues. We understand that may mean we need to examine how we do what we do and where we have created, maybe not willingly, but where we have created barriers to resources and to support. We're committed to doing that. And we've heard loud and clear from community advocates that they are best positioned to help those in their own communities. That it is them, as community leaders on the ground, who have been working to provide community solutions for generations. It is them who are able to really affect the change that we need in this moment. And so the department has been really trying to think critically about how we engage with those community leaders and how we can best utilize their expertise to disseminate resources that will have the greatest effect. To do so, I want to talk about a few things we've done and what we've learned. Some of the things we've done, as Lisa covered, included increasing access to testing. Under the standing order, that means testing people of color regardless of symptoms. And in addition to just providing that increased capacity of testing, we also have been working with providers to do a webinar series aimed at increasing awareness about the need to do such testing, and aimed at increasing awareness about the barriers to testing and how best to collaborate with community health workers in order to achieve that. We've also looked at our contact tracing system to ensure language capability and hired people who have the ability to speak directly to folks in the languages, in their native languages, so they can understand the process when they've tested positive or when they've been exposed to COVID. This work isn't just happening at the CDC, although it is certainly the health department. It's happening across offices in DHHS. We come together regularly to discuss these issues and how each of our offices can best serve those in need at the moment. Some of those things across our offices that we've done to reduce racial disparity include increasing Maine care coverage to cover for those Maine care members, increasing coverage to include testing and treatment, including those in emergency Maine care benefits, also covering testing and diagnostic services for the uninsured individuals. We've also targeted support for group home workers, which has a particularly diverse workforce. Our Office of Aging and Disability Services has worked with cultural brokers to control the spread of COVID-19 by trying to reduce barriers for fit testing and infection control. We've worked with the Office of Child and Family Services to provide translated guidance and support for parents. And our Office of Behavioral Health and Commissioner's Office have supported the Maine Frontline Warm Line, providing psychological first aid to first responders and staff of healthcare facilities, understanding that many people working in these settings are in fact people of color. The Office of Behavioral Health has also, through its Strengthen Me initiative, developed contracts with ethnically based community organizations to retain services of community health workers who will provide outreach, assessment, support, education, and resource linkages to communities disproportionately affected by COVID. We've heard really loud and clear that it is really difficult to comply with public health directives around isolation or quarantine needed to control the spread, given the conditions and the economic realities that some of our communities face. As such, we have looked to provide additional social support for individuals who need help in order to isolate or quarantine. Those social supports include working with Maine Housing to safely quarantine and isolate in hotels where folks are not able to do so in their own homes. We've also worked with community action programs, Catholic Charities, and Wabanaki Public Health to deliver social services to individuals in need of that help to isolate or quarantine. The hope has been that those services will be delivered in a culturally appropriate way, using translation, interpretation, and other cultural brokering where possible. What we have heard, however, is that in our attempt to do so, it did not always work. And that is why in this next round of funding, which I believe was mentioned early on in the introduction, in which Governor Mills has committed $1 million to reducing racial and ethnic disparities, that funding is intended to go directly to community-based organizations. That funding is intended to go directly to organizations that have the ability to work with the communities from which they come from and lead. The hope is that those social supports will then meet the needs as best understood by those in the community. That application for funding is now live as of this morning, and I'm looking forward to seeing how we can collaborate with community partners on that funding moving forward. I started by saying we understand that this means we have to examine how we do and what we do it and what barriers that produces. In an effort to do so, the department has also issued a request for information, seeking to better understand how we can improve equitable outcomes for health and human services programs. The request for information gathers public input on the department's organization, grant and contracting processes, and engagement with many communities in Maine. It's our hope that through these efforts we can begin to address some of the disparities that we're seeing, but we understand that it is not going to be an easy or a short fix. These are nuanced challenges for a diverse community of people, and there are many barriers. We are, however, committed to working alongside our colleagues, both in the department and in the community, to help improve these disparities.
Thank you, Leana, so much. I really appreciate it. And thank you again for being with us today. And jumping right into our next panelists, we have Maine State Representative Craig Hickman. a familiar name and a familiar face I'm sure many of you recognize. Along with being a state representative, Craig is an organic farmer. He is a small business owner, a poet, and an author. So we are thrilled and excited to have Craig with us today to provide some of his insights on racial disparities and COVID-19. I see he is here on screen. Hello, Craig, and I will let him go ahead and take it away from here.
Good afternoon, everyone. I'm blessed to be here today as part of this vital conversation. I'm humbled always to hear the words of Crystal Cron. I was not sure what I was going to present today, but I realized I have something we've been working on for a long time. And some of it you have already heard, but I want to further contextualize the moment that we are in and why we see these racial disparities, and what we also must not forget. This essay is offered in good faith. It serves not to divide, except to understand what the perspective of an Indigenous African American is in these very tough times for our nation and our state. It was co-authored by Representative Rachel Talbot Ross, who many of you know, a 9th generation Indigenous African American Mainer, serving in her 2nd term. She is the first African American woman in history elected to the Maine legislature, and she represents the most racially diverse district in our state. It was also co-authored by Michael Kabeda, who many of you know. He is an Ethiopian immigrant who moved to the United States at 17. Much of his family immigrated to DC in the 80s. The views that are expressed in this work are his private views and should not be attributed to his employer, the ACLU of Maine. And I also want to congratulate him on his appointment to Portland's Charter Commission, which will do the work of looking at the structure of Portland government. This piece should be published this weekend in the Portland Press Herald. It is called Getting Our House in Order. Black lives won't matter until we answer for the sins of slavery. And it goes like this. A mass movement roils the nation against the backdrop of a global pandemic that has cut short too many lives. George Floyd's broad daylight murder under the knees of the police was the spark that lit the movement, although the injustices that inspired it stretched back more than 400 years. In cities and towns across America and around the globe, hundreds of thousands of people from all backgrounds are coming together in the youth-led movement to demand the end of anti-Black racism and systemic inequality. These protests are the newest chapters in the long Black freedom struggle epitomized by the dearly departed John Lewis, the youngest speaker at the 1963 March on Washington for Jobs and Freedom, and characterized by Black activism, self-determination, and resiliency. John Lewis reminds us that we are one family, one house. And so to honor his memory and carry forth his legacy, we must begin anew. We must get our house in order at last. As the great African-American author James Baldwin proclaims, I love America more than any other country in the world. And exactly for this reason, I insist on the right to criticize her perpetually. We too love this country more than any other, and this moment requires an uncomfortable critique of the realities that have facilitated endemic disregard for Indigenous African Americans in favor of waves of immigrants of all races, no matter how harshly history has treated each influx. Our country's partial answer to her recent crimes against immigrants must not excuse amnesia or her twin original sins of genocide and slavery. Black Lives Matter. Marchers chant these words in unison, companies proclaim them in public relations campaigns, public officials bullhorn them at demonstrations and utter them in interviews. They are painted on t-shirts, stenciled on homemade placards, and painted in large gold letters on main thoroughfares around the nation, including the road leading to the White House. Public art that John Lewis was able to set upon his eyes before he died. Black Lives Matter. Alicia Garza, Opal Tometi, and Patrice Cullors coined the phrase. Like all human beings, they embody multiple identities, but they collaborate across difference. Tameti is the second generation Nigerian American founder of the Black Alliance for Just Immigration. Her parents were undocumented. Colors is a queer Black artist and founder of the Coalition to End Sheriff Violence. Garza is the queer daughter of a Jewish father and a Black mother. The system might simplify their identities, reducing them to one Black immigrant and two African Americans. Their collaboration, however, reveals a truth about Black liberation. For all of us to be free, we must find solidarity across the chasms that those in power exploit. Divide and conquer, a doctrine old as dirt, has pitted Black people who immigrated here from the African continent against indigenous African Americans who have survived genocide and the atrocities of chattel slavery in this country. But we must begin anew. America owes indigenous African Americans a great debt, for the economic wealth of this nation was built with Black bodies and the degradation of Black lives. Payment of this debt means not only reconciling that our bodies were once a form of currency in this country, a product bought and sold, but also tackling the aftershocks of chattel slavery, Jim Crow, lynching, and more. Dr. King spoke of this as the promissory note that remains in default, an oft-forgotten and overlooked passage of his speech at the March on Washington. In spite of this, indigenous African Americans have watched as wave after wave of immigrants arrived on these shores and surpassed them on the social, political, and economic ladder. Black immigrants arrive on the shores of the United States fleeing failing states, warfare, and economic catastrophe and devastation. Many of these ills are the fruits of Western perfidy, as Walter Rodney, William Easterly, and others remind us. Belgium enslaved the Congo with the help of American newspapers, and the United States snuffed the National Democratic Movement when the CIA helped assassinate Patrice Lumumba in 1960. Too many more stories like this define the West's relationship to Africa, the primary source for immigrants to Maine. And yet, the racist soup that stews in America is uniquely devastating to those who have simmered in it longer, the descendants of Africans enslaved in the Americas. Those whose countries American imperialism wrecked have still had the buffer of native languages and cultures, some distance from the lethal toxin of endemic American white supremacy. This reality has resulted in disparities in income and health between them, putting the average African migrant above the indigenous African American in metrics that matter to quality of life. Data show that the household income for Black immigrants is lower than Americans overall, but higher than indigenous African Americans, evidencing a system that has left Native sons and daughters too far behind. The current pandemic further proves the point. More than 1 in 4 people who have tested positive for COVID-19 in Maine are Black or African American, even though only 1 in 60 Mainers identify as Black or African American. More than 1 in 3 Mainers who have tested positive is a person of color, even though only about 1 in 20 Mainers is non-white. The federal government has been derelict in addressing this crisis. The United States has too long led the world in COVID-19 deaths and infections. Our Surgeon General's first response to disproportionate Black death was to urge Black and other people of color to, quote, avoid alcohol, tobacco, and drugs, end quote. This is to say nothing of the dysfunction and abject failure of the White House, leaving state and local governments to find a way out of no way. But as the New York Times makes painfully clear in a recent article, we must do more to protect the lives of Black people. And we must act in solidarity across differences within the many rooms of our house. Paradoxically, one way to do this is to distinguish between Black immigrant and African American or indigenous Black American in our healthcare policies. This distinction matters for epidemiological reasons. There are significant health differences between Indigenous African Americans, African immigrants, and Afro-Caribbeans. The task force convened to end hunger in Maine by 2030 disaggregates food insecurity data in this way. To the United States Census Bureau and to the Maine CDC, as we have already seen, there is only one category that captures all Black people, Black or African American. We do not know what proportion of the more than 25% of positive tests for COVID-19 are Black immigrants and what proportion are Indigenous Black Americans. Recent media coverage about racial disparities and COVID-19 infection rates in Maine has highlighted very few Indigenous African American voices. A recent Washington Post article reinforces this error by stating that, quote, almost half the Black people in Maine are immigrants, end quote, but then not quoting a single Indigenous African American voice while naming, quoting, and even printing photos of several Black and non-Black immigrants. The distinction also matters if we are to remedy historical injustices. African immigrants certainly suffer under institutional racism. They suffer housing discrimination, racial profiling, redlining, and other forms of exclusion and abuse. But African immigrants were not dispossessed in the myriad ways as those whose ancestors toiled on American plantations and were written into the US Constitution as 3/5 of a person, a codified disgrace that continues to give power permission to treat all Black people as less than human. African immigrants have not suffered the generational deprivation and subjugation of Indigenous African Americans in this country. For them, America presents dangers, but it also offers refuge and new beginnings. For too many Indigenous African Americans, despite considerable progress, America remains a place of genocide where trauma and erasure are deeply rooted, where the lash of brutal chattel slavery echoes today. Crucially, the ancestors of Indigenous African Americans were forced here in a treacherous journey that killed legions. Women and men built the new nation's fortunes on their backs. Indigenous African Americans have also given this nation some of its most significant cultural achievements and life-changing inventions and discoveries: the spiritual, the blues, rock and roll, and jazz, a uniquely American musical invention. The traffic light, home security systems, a rotary blade lawnmower, crop rotation, blood plasma. Lest we forget, Maine reaped the economic fruits ripened in the slave trade. Antebellum shipbuilding thrived in Maine, and many ships built here carried human cargo. The only person in American history to be tried and executed for slave trading, Nathaniel Gordon, was a Mainer. Indigenous African Americans have been in Maine longer than Maine has been a state. Maine's first African American legislator, the Honorable Gerald E. Talbot, elected in 1972, belongs to a family with 11 generations of history in Maine. Still, Indigenous African American communities in Maine have lacked the level of influence or political representation that a larger African American population has enjoyed in other states. They currently lack the social, economic, or public health infrastructure of Maine's Black immigrant community. Through no fault of their own, and like other immigrants before them, African migrants have been used as pawns in the nation's refusal to achieve racial justice. Black immigrants have in the past been touted as a model minority, even as they climb ladders built by the Indigenous African American freedom struggle. Black immigrant representation remains crucial as we see here today, but it does not fully address the aftermath of chattel slavery, which imposes unique generational burdens on Indigenous African Americans. This reality must drive our collection of data, and it must drive our policy interventions. African immigrant leaders, Indigenous African American leaders, Native American leaders, Hispanic American leaders, and other people of color in Maine stand in solidarity behind this principle of action. We will continue to call on policymakers and the private sector to lead with love and inclusion, not fear and division, and embrace Indigenous African American voices and experiences in their pandemic relief and recovery efforts, as well as in the long-term plans for the state's health and economic well-being. We join voices throughout the diaspora calling for structural change. As Audre Lorde told us, the master's tools will never dismantle the master's house. And so we need new tools, such as those recommended by the Permanent Commission on the Status of Racial, Indigenous, and Maine Tribal Populations. After all that Indigenous African Americans have sacrificed, willingly and otherwise, to make this country live up to its promise of liberty and justice for every human personality, it's the least we can do. Let us honor the legacies of those who have gone before us, and let us get our house in order once and for all.
Craig, thank you so much. Again, I really appreciate you being here. Thank you for those words. I'm a little bit speechless. I'm really appreciative of you being here. So thank you very much. And just in the interest of time, going right ahead, we have our final panelists, which are 3 community health outreach workers that we have on panel from Maine Access Immigrant Network. We have Sanaa Abduljabbar, we have Mohammed, Hassan, and we have Sanaa Osman. And Sanaa Osman is a board member of Consumers for Affordable Healthcare, and she is also on the board of Cross-Cultural Community Services, which is a nonprofit in Maine. And Sanaa Abduljabbar is on the board of Maine Needs, and they both hold these positions as representatives of Maine Access Immigrant Network. They'll be sharing their firsthand experiences and personal stories of supporting their communities during this pandemic. We are happy to have all of them on panel, and I think they are going to appear up here on screen, and once they do, I will allow them to take it away.
Hi everyone, good afternoon. My name is Sanaa Osman, as Tori said. Thank you so much for inviting me to be a part of this panel. I'm a community health worker with Maine Access Immigrant Network. Our organization is a community-based nonprofit organization focused on public health, research, and advocacy, and it's consistent. The board members are all refugees, and so is our executive director, and the staff is mostly from the immigrant community and refugees, and in addition to Sarah Lewis, of course. We serve refugees, immigrants from Middle East mainly, and Africa. And we are a multilingual staff or multilingual team that speaks Somali, Arabic, French, in addition to Lingala, Swahili, and Kurdish. And I am one of the Arabic speakers. You have 3 today from our organization. We're going to try to give you a glimpse of our day-to-day work that we have been doing since COVID hit. When COVID hit and we had to shelter in place and we had to stay home, many of our clients and communities didn't have that privilege. They weren't as lucky to be able to work from home, so everybody has to go to work. We started working remotely. We became so much busier, and we had to answer so many questions that our clients had for us to help them navigate all these systems, social health system, employment systems, and these systems were already difficult for them to navigate even before COVID hit. And so we continued on doing our work that we were doing only virtually, things like case management, doing virtual language-specific peer support groups that continued on. These groups were in partnership with Greater Portland Health. We also started delivering masks, delivering food, doing home deliveries to different things that are getting donated to our organization. Misinformation and confusion were the main thing that worried us at Maine. So we started our YouTube channel, COVID YouTube channel, in which we uploaded some videos about in our languages, to the languages that the community speaks. And they were basically about what's coming up, any information from the CDC, anything we're getting from the WHO. We were talking about basic things as washing your hands, wearing a mask, and then we started to try to utilize as many of the social media platforms so we can connect with our clients. One of the series that we started was Ask a Doctor series in partnership with the physicians from Maine Med, and these series were they're still going on in the 4 languages actually that we speak. As I said, Somali, Arabic, French, and Lingala. And we invite the community on a Zoom call and have them ask any question that they want to ask our doctors and physicians. One of the ways that I personally was using to connect with our community, I'm part of the Sudanese community here in Maine, and I was part of a WhatsApp group that had 90 people of the Sudanese community, and it was just a social group when this group started. So I started posting things about everything, about the disease itself, about whatever information I'm getting, and translating it and sharing it with my partner Sanaa, who also speaks Arabic, and so she can share it with other communities. And we did this back and forth, me and her. So we talked about unemployment, how to apply for it. We talked about Maine Care, if you qualify for it or not. We talked about food stamp. We talked about TANF, the stimulus check, and people who weren't qualified for it, or how can they get it, or they're not automatically getting it for not filing taxes. The census, car registration, anything that the governor was coming up with, the emergency issues, so everything you can think of, I started talking about it. And so in the beginning, people were not replying back to me on the group. And I was like, maybe I'm bombarding those people. I'm just saying stuff that they don't need. And when I said, do you guys need these things? Are you okay with me posting in this group? And everybody was like, oh my God, you gotta continue on doing this. This is very helpful. And I started getting contacted from people who were not in the group, because those posts were sent out of the group to people who needed my help. And so I started this journey of learning about these services as I was helping my clients. And a lot of fears and issues that were happening to our communities. I can tell you one story of a client who applied for, she lost her job, her and her husband. He didn't qualify for the unemployment insurance because he was self-employed. So it didn't come up for the self-employment. The pandemic unemployment assistance didn't come up until May. So he didn't get any money, no income. He lost his income. His wife, when she applied, it took her like 8 weeks to get unemployment. So the landlord was bothering them, they felt threatened. They felt like they're going to lose their home, they're going to get evicted. So I helped her helped her apply for the rental assistance. It was only $500, but it did help. And I did connect her also with the financial legal, where they were able to help her not to worry about that issue. And so there's a lot of small stories that I can tell, but due to the time, I'm gonna also, my colleagues are gonna tell you more stories. And for COVID-19 has been really hard on our communities, because they're not only worried about their family members who live in this country. They're not worried about your immediate family, your kids, your wife. You're also worried about your extended families, your parents, your siblings who live back home, who live in a really non-existent health system. So this has been an enormous amount of stress on our communities, and they have been really worried about their community members. I remember a story in April when we had a community member who lost her niece, and her niece's husband both died, and they left behind 6 children. And so this has been really hard for the community that we serve, and we have been trying ever since, and still doing it, to support them as much as we can, and to continue on this support and do our best to work with everybody and anyone that we can help in these communities. I will stop here. Thank you so much again, and I'll introduce my second colleague, Mohammed. Dr. Mohammed, please go ahead. Thank you.
Thank you, Sanaa. Thank you for inviting me this panel discussion. My name is Mohammed Hassan. I work with Maine Access Immigrant Network as a community health worker. Before coming to the United States, I was a physician in my country, providing healthcare to my people there. Before coming to this country, I witnessed many outbreaks of diseases, infectious diseases like cholera, measles, chickenpox, and all the other infections that a human being might think of. I also witnessed a civil war in my country where people were killed by, people were killing each other when they wanted to change the system of government. And I think many people, many of the communities that you see today here in Maine and in other states were the victims of this civil war. There was an exodus of refugees ending up in a second country, neighboring country, spent years in refugee camps. And those who were lucky enough were able to come to the United States and in other countries to start a new life. They have seen some form of disparity, discrimination, racism, whatever you call, in their home countries because of the institutions that were existing at the time there. I also have experienced and have seen hospitals full of incapacity because of the civil war. People being treated in parking lots, under trees, and sometimes surgery performed without or the minimum anesthesia. Today, in Maine, we are experiencing in the United States, the safe haven that we came from our country, we are seeing when this pandemic started, people were so scared. They shared the emotions and the anxiety with all other communities. Plus the disparities, which are already other colleagues have spoken out, which are deep in the system, where before even the COVID, navigating the system was difficult. Mainly understanding even the system, the healthcare system, which is very difficult to understand even for the mainstream population. I wanted to share you what I have seen because of the time, and I wanted to be brief as possible. What I have seen during this period in the COVID, since the COVID pandemic. During the early days, when things were not like they are today, I have noticed that most of those who were affected and tested positive were young people who were working frontline jobs, frontline occupation jobs like healthcare, transportation, food production services, and others. Unfortunately, these young people, most of them in our communities, they were living with their parents. And once they get infected, they will go back to they have to go back to their homes, and the risk of infection will be great since they are living in a space where there is the possibility of getting of isolating or having a separate bathroom or a bedroom or one bedroom separate for each one is very difficult. I thought of what we can do for this. And another thing is those parents and elders who are in the home, some of them have underlying conditions, hypertension, diabetes, asthma, which are risk factors for getting COVID and also a bad outcome in case they are exposed to the virus. So I thought of this, and I communicated with the community leaders, faith leaders, and others, and we said, how can we? Is there a way that we can help? I thought of an idea that, because I get to know that many of these young people who are working in home health care centers, transportation, and as I said, food production services. And as you know, people are worried of their jobs. So if you start, if you stop working and stay home and you follow the orders as they are said, later on you will be fired and you will not be able to go back to the job without getting permission. So I thought of a way that we can help them. I suggested with other community leaders that we can advocate for those people who have at least the underlying conditions like diabetes, hypertension, and asthma patients and others, a way to contact to their primary care healthcare providers with the consent of the patient, and ask them to make a recommendation letter that says it will be to whom it may concern. It will not. They are not. They are not able to directly write to the employer, but at least emphasize that these people have underlying conditions, and once if they are exposed to the virus, the result will not be good. So we recommend them to stay home and avoid anyone who might be carrying the virus. And also to include the letter that they are living with their children who are working in frontline jobs. That letters were issued to although it took time because at the time, even the health providers were very busy at the time. It took time, but at least for some it came. We gave these letters to the young people who were working to give their employers. Luckily, some of the employers gave them leave without pay for some. At least they found like around 12 weeks to stay home and take care of their parents. And that was a success, and it was a very good thing to do. People, but unfortunately, others were, after 2 weeks, were fired and they lost their job. And that was what I wanted to share about. I wanted to be brief in my presentation, but thank you for letting me to say this. And this is a long topic, and I think it will need more discussion. I will give the venue to my other colleague, Sanaa Abduljabbar, and who has done a great job providing services to this community. And thank you very much.
Hello, everybody. This is Sanaa Abduljabbar. I'm one of the community health workers with Maine Access Immigrant Network. Thanks for having me as a part of this panel conversation. I can say like racial disparities in healthcare are not something new or a new issue that's been happening. It has been going on for a long time. COVID just makes it more urgent than ever. Starting in mid-March, Maine expanded on our collaboration with our existing partners, such as Maine Needs, Presente Maine, the Opportunity Alliance, and other local neighbors donating foods and cleaning supplies, making masks, donating thousands of masks for adults and kids as well, and gloves, which our team distributed to all people in need, not just our refugees and immigrant population. Translating all information about COVID and sharing them with our community who we are serving through WhatsApp, Viber, and texting messages, from a new executive order to rules about masking and school, making sure parents, kids, everyone in the household understand how to stay vigilant in protecting the family and community when visiting ethnic stores as well. I can talk about specific case that for one of my clients. I had a client who arrived here years ago as a refugee from Iraq. He has multiple existing chronic illnesses, including hypertension, depression, anxiety, paranoia, uncontrolled asthma, PTSD, and others. And right now he is losing his vision for one of his eyes. COVID has delayed this client from getting treatment for his eye as it is not considered essential. He is a main care patient and therefore he cannot pay his way to an expedited treatment plan like someone who can pay their way or who's on private health insurance. COVID has completely stalled this client's usual care. It's not easy to be relocated to a country when it wasn't your choice to leave your home country, where you don't speak the language, where your degree, your life experience, everything is not valued, where you have to start over and over again. You really have to try to forget the past to be able to wake up each day and really live, to make progress in your life and the life for your family as well. COVID on top of all this just makes what was difficult more difficult, but we know we are resilient. We are resilient because we are still standing even after being forced to leave our homes, our families, our friends. War, lose, we are still standing there. Thank you so much for having me and for listening.
Thank you, Sanaa, and thank you to Sanaa and Mohammed as well. We really appreciate your time. Thank you to all the panelists for being here. It looks like it is 1:23 now. I know that we need to end at 1:30. So we are going to try and do a quick Q&A, and obviously we're not going to get to everyone, but we will at this time try and bring all the panelists back on screen so that we can try and get to 1 or 2 questions before the 1:30 mark. And I will also be introducing on panel to kind of take over the Q&A, GPCOG Zoe Miller, Director of Community Engagement. So Zoe and the panelists will have a dialogue and hopefully get to some of the questions that we have once we can get everyone back up on screen.
Hi everyone. This was even better than I think we anticipated, and we're just so pleased to have many different perspectives. You know, I think as it's been discussed, this is a complex issue, and so the solutions are really complex. And I think given that we don't have a ton of time left, we are going to turn it back to Christina to close us out in a few minutes. So if I could ask folks to be just very, very brief. I think, you know, as you know, our GPCOG is a Council of Governments that is composed of our members that are cities and towns. And so we like to talk about the unique role that cities and towns have to play, so that elected leaders and elected and appointed municipal leaders have to play in issues. And I think with health issues, often it can be easy to think that it's not an issue for municipal government. You know, healthcare isn't necessarily in their bottom line. But I know I don't have to tell any of you that they do have an important role to play. And so what I'd like to do is just maybe do kind of a Zoom round robin of just your, you know, very briefly, what you would like city and town leaders to, what you'd like them to take away from this, you know, sort of your top requests to them. And I'm going to start with Crystal.
Sure, thanks. So for me right now, the biggest thing is housing, and the municipal housing fund that was released a couple weeks ago. It's an 8-page document where you have to prove, you have to get a signed letter from your landlord. Many of the people that I'm in community with don't even know who their landlord is. So yeah, the application is just a huge burden, and it requires way too much documentation. And I just don't know why poor people have to prove so hard that they're poor. And then the other thing is school. I have real concerns about school opening up. You know, we know that Black and brown students, their parents are essential workers, and you know, it doesn't really matter which way the infection flows. Like if their parents get it at work, they give it to the kids spread it at school, or a teacher gets it and gives it to the students, and then they give it to their parents and they spread it at work. Like, I just think that we can't be the babysitters for companies, and that we need to be thinking about our students, and our families deserve more. So I hope that we can continue to get food and all the other services that low-income students access at school in a different way, and be more creative, even if it's harder.
Thank you. And I think we probably have time for just one more person. And I think I was sort of looking at either Representative Hickman or Sanaa Osman, if you want to have the final word.
I think that local government leaders should embrace food sovereignty. Access to nutritious food and community resiliency is not often talked about as a part of one of the solutions to this pandemic. We are what we eat, and our diets are essential to our life and to our livelihoods and communities. And so municipal leaders should be embracing food sovereignty to the extent that the communities want that. Because right now our food supply is in trouble and hunger has increased by 700% in the last 3 weeks. And we must not lose sight of the fact that at the very basic level, we need to eat in order to live.
Thank you. Thank you all so much. I think most of the questions that came in through the Q&A did get addressed. We will be taking in, if you have additional questions that you'd like to get to a panelist, GPCOG will be handling those. You can send them to info@gpcog.org. And I'm going to give it back to Christina Egan to close us out.
Thanks, Zoe. Thanks, Tori. Thank you to all of our speakers today. Great panel. And thanks to all of you who've been participating. I wanted to just summarize some high-level takeaways that I had from this, and drawing also, as Rep. Hickman talked about, on the Permanent Commission on the Status of Racial, Indigenous, and Maine tribal populations. It has a very good structure for us thinking about how to move ahead. The first is that we need to be aware. We need to understand what's happening. And we had great data presented today, and now the state is presenting it in a way that actually very transparently shows the racial disparities. But as the recommendations state, awareness is not enough, and that we also need to have a structural analysis. And we heard that from Lisa and Beth and from Crystal about some of the underlying issues that not only create the racial disparities that was a precursor to COVID-19, but also to all of the inequities that we're seeing in our society. We also have heard, and I think this is very critical for white decision makers to think through, is that the solutions really should be designed and led by the communities that are most affected. So if we take that as some of our guiding principles about how to move ahead, for cities and towns, we've heard some specific ideas from Crystal and Representative Hickman about what they can do. I want to underscore one of the bullets I saw, which is that municipalities can hire community health workers, just like the ones from Maine Access Immigrant Network that we heard from today. That can be very helpful to have people from those communities that are most affected doing some of the outreach and paid for by municipalities. Also, I heard it's important for our municipalities to communicate what social services are already available in ways that are understandable to diverse populations. And at PACS, we've been doing a lot of work to try to translate, interpret, make things understandable to a wide variety of different populations. And we need to do that with our general assistance and other kinds of social services. So I'm going to conclude just by saying that GPCOG is not an expert in racial inequity. And I said this before, we don't know what we don't know. We invite you in helping us design our next webinar and the webinars to come. Our next one will be on education and disparities in education in Maine. It will be held in September. So many of us who are white are actively reading, understanding history better, trying to hear the stories to better understand the structural racism that is not necessarily visible to all white leaders. And so we want to thank you for joining us on this journey. I think we're all on this journey together. And our hope is that we as a region and as a state can really learn together and we can have genuine dialogue. And that means that we have different and diverse voices that we are bringing to the table. Some may be difficult for white leaders to listen to, some may be easier, but it's important for us to have all of those voices represented as we move forward together, because that's how our region and our state will get stronger. It's when we understand that all of us have an interest in the potential of each person being reached. And we can only do that by looking at the disparities that we see on the surface, the symptoms, and addressing the structural racism and institutional racism. So I want to thank all of you for participating today. We look forward to seeing you next time when we talk about education. And again, we invite you to be in touch with GPCOG staff as we continue to design this series. Thanks so much.